Good morning, and thank you for joining us for Winship Grand Rounds this morning. If you're an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the access code today is 323304 and can be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with this webinar or the CME login, please send Janelle Taylor an email or drop a note via the chat feature. This morning, we are pleased to welcome Dr. Erin Gillespie. Dr. Gillespie is a radiation oncologist who specializes in the treatment of patients in breast cancer and metastatic disease. She's also a health service researcher with a focus on defining gaps between evidence and practice, understanding how to evaluate measures of quality, and developing strategies to improve cancer care. Her methodologic approach is grounded in implementation science, and she's completed the NCI's Training and Dissemination in Implementation Research in Cancer and an MPH from the Harvard T.H. Chan School of Public Health. Dr. Gillespie is an associate professor at the University of Washington Fred Hutch Cancer Center. Prior to this, she was an assistant attending at Memorial Sloan Kettering's Cancer Center and director of radiation oncology for the MSK Cancer Alliance, in which she oversaw clinical trial enrollment and led an NCCN-funded initiative leveraging this community academic partnership to improve access to specialized care closer to home for patients with metastatic disease. Her prior and ongoing research includes using large databases to understand patterns of care in the United States and evaluating implementation strategies to reduce low-value care and improve quality. In 2015, she founded a clinical decision support tool, eContour.org, that is in use by radiation oncology professionals in all 50 states and over 80 countries, and has been funded by multiple agencies, including the Agency for Healthcare Research and Quality. Dr. Gillespie attended the University of Michigan Medical School, where she completed a research fellowship through the Howard Hughes Medical Institute, focused on bringing research findings from the lab bench to the bedside. She completed internship in preliminary medicine at the University of Washington and residency in radiation oncology at the University of California, San Diego. Her research awards include the Rankin Resident Research Award, ASCO Young Investigator Award, RSNA Education Scholar in Innovation Grants, and an NIH KOA Career Development Award. Please welcome Dr. Gillespie today for her talk, Implementation Science in Digital Health to Promote Equitable Access to Evidence-Based Radiation Oncology. Thank you for joining us.
Well, thanks so much for the warm welcome. And so really the background for, I include this picture of the map, because when I was in middle school, my family moved from Los Angeles to Anchorage. And it was shortly after that my mom was diagnosed with breast cancer. And at that time, she received surgery and radiation back in Los Angeles, but she got her chemotherapy in Anchorage. And the radiation part of things really like uprooted our family for a whole summer. We went, 6 weeks of radiation. And since that time, I immediately got involved in breast cancer research, and I am fortunate that Dr. Jagsy shepherded me at the University of Michigan into this field of health services research. But really questions around why does care vary? How can we have confidence when we might have actually been able to get radiation in Anchorage that was high quality, and we may have just not known. Now I know the radiation oncologist there, and I actually have good confidence that would have been a reasonable option. So understanding like how do we measure quality, how do we just help patients get treatment closer to home, to be honest, is really the main theme here. So I'll take you on a little journey through some of the things that Dr. Lynn mentioned, but my disclosure being that eContour is funded by educational and research grants. So we'll talk a little bit about practice variation and where, how this work has kind of moved into the field of implementation science, and then some specific examples of implementation efforts. And then I'll talk about our bone mets trial and thinking about how to integrate implementation into kind of the therapeutic trial pathway. So some of my first work really started with, again, this question of, by the time I was in residency, we were moving from 6 weeks of radiation to 4 weeks of what we call hypofractionated radiation for whole breast. And one of the early questions was, just as a resident, noticing that there were differences in who was offering it, who was getting it. And so this led us to, do a national study just looking at the variation in receipt. And the interesting thing was really, we thought we would see that rural areas would tend to have more, short course radiation just because of travel barriers among patients. But what we actually found was almost the opposite. Although rural urban itself didn't have any correlation, what we did see was that higher density of radiation oncologists led to more short course, which is that something around, peer review, or, just access to knowledge, and, groups. There's some work from James Yu's group around, how even teams of physicians can kind of promote guideline-based practice, or were there market forces at play? But at the end of the day, what we saw was that, patient factors tend to matter as much or less so than the clinic and the physician that you actually go to. So this has driven a lot of the questions around, like, just the quality of care and how important it is, the physician that you see and the clinic that you go to, and how do we address that? Around the same time, there emerging evidence from RADONC clinical trials around this volume outcome relationship, which often it was kind of started in surgery, where we know that, high volume surgical practices for complex surgeries tend to have better outcomes. And because it can be really difficult from a statistical perspective to actually define an individual person's volume, a lot of that has led to interventions at, moving patients to high volume centers. We also don't know specifically if it's the individual or the team in the surgical setting. But, data was emerging in radiation oncology as well, that, including from our group, that particularly for head and neck cancer, as we were moving from 3D conformal into IMRT, you actually saw a difference based on, the individual radiation oncologist only when you looked at IMRT, but not 3D conformal. So saying, as complexity rises in our field, we have more imaging, but more ability to do complex treatments, that who you see may matter more. And this is where, these lines of thinking sort of met. As a resident, we developed access to imaging-based guidelines and contouring, was one of the things that we as residents were, noticing that these resources are all over the place, and how could we, and one of, at the time, my mentor, Jim Murphy, had come from Stanford, where he'd had on a CD about like 12 cases that were head and neck cases that were just how Quinn Lee treated. And I thought, what a great resource that only Stanford residents can carry with them. And so how can we do something like this that, wouldn't just be for UCSD residents, but we could actually share with the country, and if not the world. And so that started eContour. We did a quick focus group at our annual meeting among residents to build enthusiasm. And then we had some pilot funding to put together the website and do a small resident-based randomized study of using it versus not using it. And since then, we released it publicly, and we've continued to iterate. We now have 47,000 registered radiation oncology professional users across the world, including about half of US radiation oncologists. And, at least a third of those are regular users still today, which is pretty impressive for a website. But really what I learned from this process is, websites and education is sort of a strategy to disseminate knowledge. And this is kind of going to where the field of dissemination implementation really grounds itself, which is on this gap between what we know works and what patients actually receive in routine care. This was updated just a couple of years ago by the NCI, where they took a handful of evidence-based practices. They tend to be more in the sort of screening prevention space, but redefining this, we had said for decades it was 17 years, and now this updated it to say it's still 15 years. But implementation science is really taking, trying to integrate, to understand and accelerate the integration of these evidence-based practices. And it really became sort of a field that people were paying more attention to. With the Cancer Moonshot Initiative, it was one of the 7 working groups in the Blue Ribbon panel. So to bring it to, so thinking about the eContour website, diffusion is publishing research and kind of letting, dissemination tends to be more active dissemination efforts, like publish guidelines and then efforts to go beyond published guidelines. But ultimately, implementation is really taking that next step, which is to really more active strategies. And one of the rationales for why education is, knowledge is necessary but not sufficient. I think I'll get to. Well, I took up that slide. So one of the reasons that education is considered necessary but not sufficient is really that people that tend to access educational resources are not always the ones that need it the most. So there's like this Dunning-Kruger effect that has been, there was an article in JAMA, in the early 2000s saying that it's actually can be the opposite, that the people that need the information the most are the ones that are not seeking it. And so that's why just purely dissemination efforts can fall short. So within implementation science, the field has tried to define strategies, really how do you call these strategies in order to enhance our ability to study them, common ones being tools for quality monitoring, audit and feedback, incentives, default options, and then some recent efforts to really integrate this knowledge from the field of behavioral economics, which is something that I've been a visiting scholar at Penn through their cancer PC3I, and they've really pushed this field forward, which behavioral economics, as we are trying to apply to healthcare. You think of it, it's really that humans are predictably irrational, which is kind of what this was a shift in our understanding of just human behavior, that we don't always do what's in our best interest. But by understanding how we make some of these errors, we can sort of leverage them to design the environment and design to just help humans make the right decisions. So the emphasis a lot on incentives, both financial and often non-financial incentives, and then again the design of the environment to really nudge you in the right direction. So the classic examples of these, I'll give a couple, are default options, bundle payments, how you set targets, whether they're, if you set them outside of what you could achieve, that they can actually be a deterrent, for example. So the default option, the classic example is from, organ donation. If you look at countries that were opt-in, you have very low rates, and then when you look at opt-out, so you have very high rates of people that are obviously in these programs. So just a reminder that setting defaults can be one of the most powerful potential strategies, just and setting them thoughtfully. So that was one of the first studies that Penn did in radiation oncology, just saying, for routine imaging and palliative radiation, if we set a default strategy, can we reduce over imaging when it's not necessary? They did a stepped wedge trial, which I'll talk a little bit about later as well, but it's stepped wedge randomized trial, meaning they took multiple centers and they randomized the order by which they rolled it out. So it allows you to still roll out the intervention to all the clinics, which can be positive, but by randomizing the order, you reduce a little bit of that bias around who's going first. It allows you to maintain a control group for a little bit longer. And they saw huge differences in reductions of these images. So in radiation oncology, we have, this is where the development of quality metrics, there's still a lot of work to be done and developing metrics that are really evidence-based and supported, but we certainly have those in radiation, dose fractionation, imaging. The development of treatment summary is something that these have started to get integrated into some of our bundled payment models, sometimes, with some question about their efficacy, but we can also think about how implementation science can affect sort of best practices that are also affecting our patients in radiation oncology, which I'll get to later. So some specific examples of this. So again, going back to short course radiation, we know that shorter treatments improve patient-centered outcomes. Different studies have shown differences in fatigue, trouble meeting family needs, even financial toxicity, variable adoption, and this emergence of really complex techniques. So which to me, we've always taken the kind of patient-centered approach that these shorter treatments, regardless of how you get there complexity-wise and health system cost-wise, are still beneficial to the patient. What we were seeing at MSK was certainly that 30 gray and 10 for bone mets was rapidly being replaced by SBRT. So for the patients that were, had good performance status, and particularly if they had any sort of radioresistant histology, but where you thought 30 gray and 10 might be beneficial. So really, being able to shorten treatment. So we had, over 3/4 of all patients getting fewer than 5 fractions. And then we also saw over time, this is showing you the main center compared to the regional network, that they're bringing these into alignment. And the strategies that we did, that the institution was doing. So again, you had the Manhattan in the center, and then 6 kind of regional, community-based, but still owned and operated by MSK. But the strategies that we were doing to really bring the whole system into alignment were to develop guidelines for each disease site. We had centralized peer review. We also had audit and feedback, at least at the leadership, at the sort of clinic level, around like, these are the practice patterns. And then the financial incentives were just not misaligned, I would say, in that, people were not paid per fraction, but they were, it was sort of new starts were sort of to facilitate. But there was actually no incentive to do more complex SBRT. But you saw that anyway. So I think it speaks a little bit to the design of these non-financial incentives and environment. And in the lower right, I don't know if Reshma recognizes that room, but like multidisciplinary tumor boards were certainly also something we even developed within the metastatic team. This is my favorite picture of a multidisciplinary tumor board, which comes from the University of Michigan, and Ted Lawrence's face happens to be in that picture. But anyway, it's kind of a stock tumor board image. So we had this success within the MSK, and we said, well, can we distribute this, across our affiliated network? So going outside of our own owned and operated to these 3 hospital networks that were in Connecticut, Pennsylvania, and Florida. And this was an effort funded by the NCCN to say, it was for metastatic disease. So we said, can we reduce the number of treatments and potentially increase the use of SBRT in order to get these treatments to our partners. We developed a multidisciplinary team dedicated to metastatic disease. We developed some multidisciplinary consensus guidelines around short course radiation, use of SBRT, but also, integrating when to involve interventional radiology, when to consider referral to surgery. And ultimately, we ran a stepped wedge randomized study where we rolled out 3 implementation strategies, where we had these sort of local consensus guidelines that we distributed, along with audit and feedback at the clinician level. So showing each physician how they did compared to others, and then e-consult. So we were available within, honestly, within an hour, people were getting email responses for questions. But ultimately, this itself did not change practice. I mean, there was a slight change over time. I think that our learning was, there was probably secular trends. Whether that had anything to do with our initiative, we don't know. But what we learned that, everyone was real excited about the guidelines, and the e-consults were really highly rated, but rarely used. They're sort of still an educational opportunity that you have to choose to use. And the audit and feedback was actually, we asked people before and after, but they found it to be more acceptable and appropriate after they received it than before. So sometimes these, people can have hesitation about initiatives that actually, they actually said this was a one-time audit and feedback, and they said, quarterly reports to track how we're doing would actually be preferred. So, was our sort of dose of this implementation strategy sort of not adequate? However, on a similar but related, we had the opportunity to actually look at clinical trial enrollment itself as sort of a best practice. And within radiation oncology, we had 59 radiation oncologists, and we were going to integrate clinical trial enrollment into our sort of quarterly clinical metrics that would be emailed out. And I said, well, let's take an opportunity to actually, so as a standard audit and feedback report, this one was more done with under quality improvement in our sort of standard processes. And so I said, well, let's actually just randomize the physicians. Only half of them will get these reports and half will not. And so we'll see if this actually helps our trial enrollment. And the answer was unfortunately no. What we actually saw was a slight decrease in those that were high accruers. So just a reminder that when these, graphs are set without, again, there were targets, but you can actually discourage use if they're not really done with the thoughtful. So again, and at the end, and this was really quarterly reports that went on for a year and a half. So we had more data, we had good follow-up. So although trial enrollment is a different intervention, certainly, it sort of gave us some pause around this clinician. So, really what we're seeing is, some challenges with clinician-directed nudges, certainly. When we think about trial enrollment, I think that a lot of people may be familiar with, the various barriers to trial enrollment. They occur at, from the, structural to the clinic, to the physician, down to the patient. So these are the different sort of levels that we think about implementation science. So one of the, key teachings is really evaluating the barriers and facilitators at different levels, really as you're developing strategies to intervene. So, and that was where the trial enrollment, as we went back to physicians and focus groups, there was a lot of discussion around, is nudging, although there are big differences from one physician to another in terms of how they're enrolling, there were certainly other barriers that may be needed to be addressed in concert with physician nudges. But so this kind of led, as thinking about clinic and physician directed nudges, to another project where we were, when I started MSK was within months of Ethan Bash kind of plenary at ASCO about patient-reported outcomes to improve survival in patients with metastatic cancer. And so MSK, and that was a single center study at MSK at the time. So there was developing expertise in implementing patient-reported outcomes sort of regularly during acute care. And so I approached this question saying, well, there's resources and expertise here, like how can we apply this? We really didn't have much experience or data of using patient-reported outcomes as sort of an intervention. So we ended up developing a system for breast radiation that was, during and shortly after treatment. We found exceedingly high response rates. 70% of patients actually responded to these surveys, which is something the Fred Hutch had been undertaking at a similar time, and we actually saw very similar response rates that, when they were at Fred Hutch, they were also looking at chemo during breast cancer, and what, the response rates in radiation were like 3 times higher than we were seeing for patients on systemic therapy. So it sort of piqued interest, and radiation is this sort of short engaged time, and some of the factors that actually increased responses were shorter treatments, and that was one of my early hypotheses was as we do these shorter treatments, a lot of our toxicity happens after that we're no longer doing weekly visits, and can we kind of leverage remote monitoring during that time after treatment? And we also saw high rates of response for PMRT, which we know have the most side effects. And then patients living further away, and prior chemo also was dictating some of, some increased toxicity. Clinician, from a clinician perspective, mostly what we heard, the approach was to really try to limit the bother, because this is, we know this from, we turned off alerts during radiation. They were not, so we were sending out weekly surveys, and they would be in the EMR, they could look at them, but they were often just asking the patient in person, what about their symptoms. And we all know about busy clinics and whether to go into the EMR and check those things before you talk to them. It was really brief. So, it was just a few key questions around skin, anxiety, fatigue were kind of like the main ones that Susie McCloskey at UCLA had really developed with the NCI team to apply to be more appropriate to radiation. And that her work exists across diseases. The other thing that we found within the breast radiation team was, this fatigue and anxiety specifically I remember getting emails that were like, when we had alerts set for these things that were like, we don't have any interventions here. So like, let's turn off these alerts. So it's like, it was, but we also recognize that fatigue is probably the most important side effect that we're really tracking and seeing frequently, but we don't have a lot to do except just sort of generically recommend that patients exercise, and we're having that same conversation. So at this time, I met the chief of integrative medicine was running a randomized trial of integrative medicine at home, which was developed during COVID to be it had a number of, there's cardio fitness, yoga, meditation, Tai Chi, so kind of a platform where patients could access, the integrative services that were able to be given remotely through a virtual website. And their eligibility criteria was moderate fatigue. And I said, well, we're collecting a ton of data on fatigue during breast radiation. And so we actually opened this breast cancer basket specifically for radiation. And we ended up enrolling 73 out of the 200 patients very quickly in a few months on the whole trial. Some of the results have been presented. Essentially, we're seeing probably the biggest symptom benefits among the breast radiation cohort. Although, they've out in the systemic therapy setting, they were also seeing some potential reductions in urgent care and hospitalization visits, which we don't see in breast radiation specifically. But so the bigger trial, we were able, so we took our PROs and instead of just rolling it out to everybody, we randomized at the physician level so that all patients of half of our physicians actually received automated invitations based on PROs. And this was just published in JAMA Onc a couple of weeks ago, but that we had the actual response and enrollment rate was even higher than I anticipated. About 35% of people that were just cold portal messaged responded, and 20% enrolled. Part of that was some definitions around our the actual in the trial, which were kind of can relax in the future, but compared to the typical like less than 1% outside of the trial or outside of the PRO prompting. And then the other thing that we learned, we did every other messaging from the radiation oncologist versus from sort of the integrative medicine team, because the behavioral economics literature would say that patients are more likely to respond to their own physician, but that actually didn't matter at all. So, and if anything, there were a couple patients that the radiation oncologist said, oh, please don't contact that patient. Not very many, but we just found that these messages actually could be sent and received just outside of the radiation clinic, so not sort of interfering with the workflow. We also saw the diversity of the patients from our basket was much more than the other baskets. Now it's different cancer types, so hard to determine, but also when you look at the patients that were messaged compared to the patients that enrolled, there were no significant differences in race, ethnicity, and ADI, which is sort of a measure of socioeconomic status. So can this PRO-directed strategy for trial enrollment help sort of reduce potentially some unconscious bias or some other factors that, make it so clinicians don't quite get to, inviting patients to these trials. Meanwhile, I'm, in my implementation science lens thinking like, how do we, this virtual integrative medicine program is actually has a significant component that's around cardio fitness, yoga, which are evidence-based practices. We've done a number of trials where we know that, particularly in breast and prostate radiation, that the best thing, the most evidence-based is practice is to encourage patients to move. And there's even, a quality metric now also to collect patient-reported fatigue from the National Quality Forum. But we know that few cancer patients are actually meeting these physical activity recommendations. Physicians are, only half report being comfortable counseling, and honestly, 85% of clinicians in an ASCO survey said this, we're really busy with the cancer treatment, that we are the only ones that can prescribe, and like, are there support services to help people get some of these supportive treatments? And that, EPRO alert fatigue is difficult, particularly when there's no prescription that a clinician can provide. So we'd also done some work with telemedicine, understanding the patient's perspective, really, telemedicine being preferred in large part due to treatment-related costs, a lot of those which are travel and lost wages from this validated survey that we were sending across all patients. And then the other factors that were associated with patient preference were people that did not have a partner or those that had lower performance status. So keeping that in the general lens of like, who really wants to avoid coming into the clinical setting. So I think where we are at, thinking about this project is really, we know fatigue is pervasive. There's also some work from radiation oncology that fatigue actually correlates really well with overall quality of life, or one of the best correlates from a symptom perspective. But actually, you can see it change a little bit more than you can see these global quality of life scales. Exercise, physical activity is really an evidence-based solution. And can this remote program sort of fill that gap of getting people being able to prescribe something, but also having something that patients can access, and really trying to use patient-reported outcomes in a more of a population health way that takes the burden off of the clinical team. Since one of my colleagues is doing a national kind of interview study of ADCC centers, and they're finding that patient-reported outcomes are really they're not being implemented to the extent that we anticipate, and a lot of that has to do with informatics costs, but also worries about the clinical load. So our next steps are to like a hybrid implementation effectiveness trial, which I will talk about in a second. But really, what kind of brought me to the Hutch is kind of additional opportunities for community-based research. So our HiCore is my research base is the Hutch Institute for Cancer Outcomes Research. It really is a network of hospitals and cancer centers, clinics around the state of Washington, which is our Cancer Center Core Grant really serves the state of Washington. There's been some discussion about whether Alaska would be included, but for now it's Washington. Although we, through the WAMI program, through the medical school, we do serve that 5-state region. So there's also opportunities in the 5-state region that differ. But so our current, this is just showing you sort of ADI scores for the Manhattan area. So as we think about this integrative medicine at home program was really conducted, and when we looked at, the actual ADI scores of our patients at MSK is very different than the state of Washington. So can we scale this to because we've heard from patient advocates, really the idea of disseminating these any sort of integrative programming outside of these major cancer centers to patients that don't have access is something that they're really excited about. And we'll find out, can we actually scale it to other centers? Can we get it to patients that are truly rural and not sort of in the suburbs of a wealthier area? And then SWOG is the other sort of, the Hutch is a statistical base for the cooperative group. And so we've been lucky to have multiple discussions around what could be a next steps for sort of SWOG's NCORE, which is the NCI's Community Oncology Research Practice Network. So each cooperative group works with the NCORE essentially. And this is just sort of a map of where that exists. So thinking about, how would you design like a next step if you were I think, and where we are landing is, the kind of, as I'll talk about, like implementation trials are probably even most applicable to the SWOG setting. And so we're sort of in this early hybrid, still needing to prove effectiveness in different places. So next steps really within our smaller network, and then scaling it to a SWOG through like the Cancer Care Delivery Research Committee. So that takes me to really where this pipeline that I've been alluding to, but not shown you, but where, when we do these single center studies, we're really talking about efficacy, like does something work? And then as we move into multiple centers, more diverse populations, we're talking about effectiveness. And then ultimately, implementation research usually comes at the very end. But hybrid designs being the idea that as we're doing the effectiveness research, can we integrate questions about implementation, barriers, facilitators, strategies to really shorten this timeline from, first evidence to patients actually getting it. So a type 1 is primarily an effectiveness trial that also collects data about implementation versus type 3, which would be more of an implementation trial. And this is showing you one of the sort of outcome models from implementation science about what some of those upstream implementation outcomes can include: acceptability, appropriateness, feasibility. And so as I also, obviously getting very involved in clinical trials at MSK, also had the good fortune to get involved and lead the trial of irradiation for asymptomatic bone metastases. So, and as I'm, thinking about like taking this with my implementation science lens, this is really an area where we have lots of good evidence for radiation to symptomatic bone mets. And what we were observing was that patients were being hospitalized with pain. And if you looked back, you could often, most of the time, you could see that where they were having issues on imaging at least 4 months prior. So it kind of led to the question, can we actually intervene early to prevent, these kind of hospitalization events? The primary endpoint was determined to be skeletal related events, which would encompass, it was kind of a common endpoint in drug trials, but fractures, cord compressions, and then surgery and radiation for pain. We were able to, within the MSK network, conduct a phase 2 randomized trial that enrolled 78 patients. And I, in my role as the MSK Alliance Director, I, opened these trials in our network as well, which that alone, we published on the significant increase in diversity just by doing that for the last year and a half of this trial, which helped make it a little bit more community-based, multi-center, but ultimately most of the patients were enrolled from MSK, and so needing some next steps. But the actual findings from this first phase 2 trial were, again, taking so patients were randomized, although they could have up to 3 lesions enrolled, high-risk lesions enrolled. The vast majority had a single bone metastasis, and these were widespread metastatic patients, so that not oligomets, because there were competing trials in the oligomet setting. So we saw differences in skeletal-related events at 1 year. It was 30% event rate versus 2%. There was some early criticism about, are we just doing radiation to prevent radiation? So, we removed palliative radiation, and still had a difference of 14% at the patient level compared to 0% among those that got radiation. And really what got people's attention, it was that we also saw a difference in overall survival. a fairly large hazard ratio of 0.5. So, hypothesis generating, essentially, that, is this something unique to, MSK's ability to treat patients or the patients that we see? So really, this is often where we think about, moving therapeutic trials into the cooperative group setting in order to more reflect the real world. And, in this process, can we confirm that overall survival is improved and learn what the mechanisms might be? And then really figuring out what patients actually benefit, because, that's been one of the comments from the NCI over and over, and I'll talk later, is, particularly when you take out radiation, you're talking about a 10% versus 2% sort of situation. And like, what about all the, the 90% of patients that we're treating that are not having these events? How can we improve on that? And really, what's the role, interaction with bone modifying agents? Because we found that 50 to 60% of patients were actually on them, even though almost all of them were indicated just based on having bone metastases. So, what are the barriers to getting those? For patients that are not on them, is there, more or less benefit to radiation? So the phase 3 trial really leverages, this is why I didn't show you the details of the phase 2, just because the phase 3 is remarkably similar. Although, we've changed it to a 2-to-1 randomization in order to address some concerns about physician and patient equipoise, stratifying by bone modifying agents, which we didn't do before, although they were balanced, and then histology, breast, prostate versus other. Preliminarily, there look like there are more events in the other category, but that was not significant on the initial trial. The other being mostly this is only solid tumors, not myeloma. The other had a lot of lung cancer in our initial trial. And again, radiation to no radiation are the arms. Primary event of SR skeletal events, but not including the palliative radiation, which those numbers end up being very similar. So we're able to power as a secondary endpoint to overall survival. The NCI, there was discussion around co-primary endpoints, but then you have to decrease your p-values. And so ultimately this was sort of has been the most acceptable approach. And also that when you ask physicians, they don't need overall survival to consider this to be an important intervention for patients that affects patient-centered outcomes. So that's the other reason that overall survival is not the primary endpoint. And then some other sort of secondary and exploratory endpoints. So the NRG took this, we shepherded this through the NRG's CPC committee with great help from Deb Bruner, who is a nurse scientist here at Emory. And this was approved by the NCI a couple months ago, and just the protocol was written. They have a quick timeline and submitted yesterday for, potentially moving this to be opening in the next 6 to 12 months. So as I've alluded to some of these issues, but thinking about this from an implementation perspective, we have this issue of the low event rate and, the costs of treatments to patients. There's certainly financial toxicity associated with additional visits and, burden to patients. Medical oncologists certainly have voiced concerns about excessive radiation and bone marrow toxicity risks, and being able to, potentially limiting their ability to give systemic agents, although this actually may be helpful if you can actually prevent events that are also competing with systemic therapy. So we will collect a lot of information about that. And then, the one thing we did learn from the initial trial was that, we had these 4 high-risk criteria: bulky disease greater than 2 centimeters, hip, long bones, and junctional spine. And you do see a difference in event rate, although the numbers in each group get very small. So actually, the junctional spine and the bulky sites tended to have more events, but we can't specifically say that with this amount of data. And then really, how do we, 2/3 of the patients were seen in the radiation oncology clinic for another area of symptomatic disease, or they were just on follow-up. And so, we recently at Hutch did we looked at all patients on, in a medical oncology clinic that were, receiving systemic imaging and had not been seen in radiation within the past year. And like 45% of patients meet these high-risk criteria. So, which is good for a trial enrollment, bad for, the idea that, we're obviously not going to have the bandwidth and we probably shouldn't treat all of these patients. So but at the same time, so trying to, at the same time sort out who really benefits, but also what are strategies to help make sure that the patients that do benefit get to the radiation oncology clinic, are some things that we're working on with our radiology colleagues, and informatics through, can natural language processing on imaging reports or even machine learning on the images themselves help us sort this out and potentially, prompt the medical oncologist about like, these are your highest risk patients, sort of some of the things that we're thinking about, although, figuring out how to do that in a way that does not further burden the clinics is going to be challenging. And then really thinking about, it's come up that in the NCI review, like MSK is a unique place that had multidisciplinary tumor boards and clinics all focused around metastatic disease. And how are you going to offer that same level? How are you going to get that same level of care? So thinking about, we've really tried to define the eligibility criteria based on what we know, and make it very clear about, the patients that may already be high enough risk to warrant surgical intervention or at least referral. And then thinking like bringing back to, our work with e-consults. It's like, is there a way, does the trial itself provide, an incentive for people to use this platform where you can, because we've proven that we have physician experts that will respond with answers, to whether you can continue a systemic therapy or which dose and fractionation you might be able to use, or, so can we integrate that in a way that where the trial would give people more incentive to use it? Because again, before, when people use it, it works really well and the response is really quick. But in routine practice, there is just a lot of, you're busy with other things. With that, I'll, kind of wrap this up. I think I've tried to share with you really health services research kind of informs us of these gaps. This sort of, that's what population data helps put numbers to the gaps between what we know works and what people actually get. And the bar is set pretty low at greater than 50% adoption in those studies. The implementation science really tries to really take this to the next step, which is to develop strategies and test them and prove, to accelerate this adoption access to these evidence-based practices by addressing things like reach, acceptability. Hybrid trials really try to, be one way as many of us in the room think about therapeutic trials, like how can you integrate implementation into, effectiveness trials to really shorten that time after, the randomized trials are positive. And that, there are opportunities in radiation oncology to really, address some of these factors, whether they're like things like fatigue that, may impact patients into survivorship. Is radiation sort of like an ideal time to really intervene and change the course of their, or the trajectory of their symptoms when they're particularly engaged, but various, potentially digital strategies we've talked about telemedicine, patient-reported outcomes, potentially machine learning and those sorts of things to really try to get, these best practices to every patient where they live. So with that, I will take any questions, and thank you for listening.
Thank you, Dr. Gillespie. If you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, I wanted to mention that the next week's Grand Rounds lecture is by Dr. Theodore Lawrence Michigan, presenting on molecularly targeted radiosensitization of locally advanced cancers. To view all upcoming Winship Grand Round lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. Dr. Jackson.
So I have a comment first and then a question for you. The comment is mostly for the audience. So we bring in visiting professors because they teach us how to think. And I think that Dr. Gillespie is an incredible example of how to think about how to advance the field. There are a few people, if anyone, that I could think of that have transformed the field so dramatically in such a short period of time. I mean, literally, it feels like yesterday that she was a medical student, but like it really is incredible to identify, and the way that she's presented things is she's systematically shown, here's what we know, here's the gap. Here's what we know, here's the gap, right? And so she has identified, you know, in some cases, we know that experts have different ways of drawing contours. Nick and I were just talking about this, right? And so where's the gap? Not everyone has access to expert contours. Here's what we know, clinical trials have shown X. And you know, if you put the frame of under treatment, over treatment, mistreatment on that, every single person in this room, especially I'm speaking to my people in radiation oncology, can start to identify something that hasn't made it into practice the way that we want it to. And so I would really encourage you, the reason we're building up our Division of Health Services outcomes and policy research here and trying to hire an implementation scientist actually is to be able to do this kind of work with our 6 sites of practice. Anything we do to improve the quality and equity of care delivery in this system can be rolled out with a step wedge cluster randomized design. And so that is the method. I will support you. I have chair development funds to do this kind of work. So if you have an idea of something we can do to make our system better, let's roll it out in a thoughtful way so we can measure. My question for you is, you showed the really worrisome thing about the nudges to the clinicians potentially going in the wrong direction for clinical trials enrollment. And it's heartening to see that when you do the targeted solicitation of patients, that you see such improvements in trial enrollment. Do you think we should stop focusing on interventions to clinicians, or what do you think we should do there? Because that's something that we're worrying about. Everybody worries about clinical trial enrollment. So what should we be thinking about next?
No. I think that, it's an interesting, you also think about your stage of your career, and that, I've been, later in your career, you have a little bit more leverage to do like system and clinic and, level interventions. And so I think that's where like we saw a lot of excitement around patient. And so like that is kind of like the first step. But then I fundamentally, patient directed nudges is only going to have like, we can really do that for supportive things. We can sort of take the clinician out of the equation for lots of things, but not everything. And when it comes to cancer treatment, you generally cannot do that. Although I think that there potentially are ways, and Penn has done a lot of, combining clinician and patient nudges to say, it's like you doing both maybe better than just doing one. So that's the other thing, is if you plant the seed. We talked about this a while ago at MFK and didn't end up doing it, but you could do prompts about trials to the patients at the same time as the physicians, and then would that be that synergy just may be more effective. Again, where we just showed that one thing alone is not enough, but you combine it with other interventions. I don't. That's it doesn't take that out of the equation. But being thoughtful about, I think one of the other big takeaways here that I think in health systems, we do a lot of things that don't actually change or improve. And I actually sold this to Sean McBride as we are going to randomize this, because if this doesn't work, we are going to remove this metric from our clinicians, because we all have so many metrics. And until we do something that we know is changing things, we are not going to burden with that. So I think that from that's just sort of another way to think about, like, within your own health system, there's a lot. And a lot of the times that does fall under like quality improvement, which can be, make the regulatory burdens, you know, you talk to your IRB about how these things are, you know, evaluated, but it gives you a little bit more leeway to make some of these changes as long as they're kind of in a like low risk, obviously.
Dr. Gillespie. It's me, David.
Yeah.
Thanks for that talk. That was great. I had a question about your idea about the hybrid. So if you're really measuring effectiveness, then I'm going to assume there's equipoise there. So you don't know which is better. Unfortunately, the field of oncology is full of many, many examples of people already jumping the gun in terms of, we know this intervention is better, and sort of skipping the generation of the evidence. So I'm just curious how that sort of is juxtaposed in terms of, if you're really unclear which is better, how do you go on to the implementation phase?
Yeah, I mean, this idea of like early adopters and, you know, like we do start doing things among select patient populations, which tend to be those in academic centers that are of higher, you know, so there are elements of that 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 you do struggle with. You know, it's like sometimes we do things earlier than is really kind of like the full evidence. And so I think that the solution is somewhere in between. The rationale, I think, for hybrid trials is to say, when we have enough evidence that it's promising, and so we need to start understanding how there are going to be differences and who's getting them. But yeah, I mean, we literally in this bone mets trial like setting, and we'll talk about, I'm sure, with the residents later, but there are a lot of people that just want to implement radiation for asymptomatic bone mets like yesterday. And we get asked all the time, like, well, who are the patients? And, you know, how do we do this? And it's like, whoa, like this was one randomized trial from a single center, like it really like proceed with caution. But there are, you know, those edge cases where, you know, people have already kind of started treating them, and this gives them a little bit more, you know, like, so we kind of accept that that's how people practice. But I think that what this sort of line of investigation has just helped me like critically think about, you know, how evidence is built, and then, yeah, at what point do you really, do you push for adoption like broadly? And somehow so you start to see why these timelines are long. But, you know, but you have to be kind of creative and thinking them forward thinking to figure out like how are we going to shorten them. Does that kind of answer? Like, so I appreciate the, you know, it's nuanced.
Well, I would just say, if there's a clinical trial and it's got a sample size and it's got measures that is going to actually prove whatever the effectiveness question is, I would just urge caution before there's an assumption that we're going to go ahead and implement this, or we already know what works better. We've just seen that so many times. So why do the trial?
Well, and that's, you know, I totally agree. This idea, it's interesting that the 2-to-1 randomization in this trial was kind of a radiation oncologist kind of preference. But when I talked to medical oncologists, they were like, well, I don't have as much issue with equipoise. Like, I don't want to send you all my patients. I think a 1-to-1 randomization might be adequate. And so it's also interesting to, you know, think about how the idea of equipoise in routine practice is like impacts trial design. So we're hopeful that a 2-to-1 randomization is a good balancing point that helps people enroll patients on trials instead of doing this outside of a trial. But, you know, the statisticians will say, like, you know, there are ethical considerations with things like that, in that, you know, you're now exposing more patients to the, you know, it increases your sample size by 10 to 12%. And those patients wouldn't have otherwise been exposed to this thing that you, so, you know, it's very interesting. Appreciate your comments.
Just almost a follow-up, but you mentioned that humans are predictably irrational. You know, and you talked about there are early adapters, there are 15 years later, and they're still not adapting it and things of that sort, which is not reason. I think, do you have ways to talk to people to get at their irrationality? You know, to make them feel safe enough to actually converse with you about the fact that they're not being rational?
I will, well, I do think that, doing this work requires a lot of trust, and building, you know, a culture of safety and, you know, people being willing to discuss areas. I think it's not, like, it's really about understanding where there's gray areas and where there's differences, and not so much what's one thing is better than another thing. It's kind of how I have approached it. And certainly, you know, the other thing I'll kind of in that vein wanted to mention is that doing the work at your own center and really like as part of kind of like a is really important for, you know, there was like Academy Health is one of the big health services. I always think about this meme that was like, you know, don't be up on stage in a national meeting and like people at your own hospital like are like, oh, who's that? Like, because you build a lot of trust and knowledge about working with physicians, particularly like within your own center, and then you can, you know, better kind of scale those things, and you also build like institutional buy-in to the work and support. So yeah, but I don't know if that's an answer, but you know, that's some of the things that I think about in doing this work. I will say that one of the challenges is that a lot of the measures are surveys and you know, asking people. That was one thing that we felt with the alignment study in the MSK Alliance with bone med practices, is that when you ask people, they're very excited about change, and you know, when you look at what they do, it doesn't necessarily match. And so that's why you need some of both. You can't, you know, always be talking to physicians or clinicians, you know, can only get you so much of the story.
You alluded to this when you were talking about the community practices, but how do you incentivize implementation of kind of new treatment methods or like shorter treatment methods when they juxtapose financial incentives with places?
Well, you know, that's the something that we are struggling with, of course. You know, the interesting thing was in the MSK Alliance sites, you know, they mostly had salary-based models. So the physicians were not being incentivized on a, you know, per fraction basis or treatment. So we didn't see any uptake of SBRT, which and that was where, you know, we really working. Tricia Santos is going to be one of your new faculty here, and she and I are working on a review article for Red Journal about issues in radiation oncology. And if you look across, like if you look at breast hypofractionation, if you look at prostate hypofractionation, there has been much faster uptake of short treatments, and part of that is when you integrate SBRT into that equation. And so I do think that's why a little bit, and you know, from a patient's perspective, regardless of how you get there, shorter treatments are more convenient and better from their perspective. And so that's where I do think, and particularly in, you know, bundle payment models would certainly help facilitate this. I think in prostate cancer, by having, you know, more complex treatments that sort of offset that financial difference has probably been helpful. But you know, at the end of the day, the financial incentives will always be there, and they will never be perfect. So you do have to And they will always be pretty crude. So you kind of think about how are the ways that we can add sort of non-financial incentives, and really try to design the financial ones to be aligned with the like patient-centered outcomes. But that's kind of the elephant in the room thing I was thinking about, which is it's there, you know, and we have to kind of think about like how can we move within that system.
Well, thank you very much, Dr. Gillespie, and looking forward to seeing everyone next week.